Thank you, Emma. Good afternoon, ladies and gentlemen. Well, this is quite a surreal experience, my first online virtual conference, not just for the HFMA, but just, for the first time ever. So today I'm going to talk to you about how can managed services support elective surgery recovery. And in particular, I'm talking about how can we support the rapid return to where we were pre-COVID. Next slide, please. Okay, well, to talk about where are we at, what is the current position that we find ourselves in today? And some of this is actually pre-COVID. So the NHS, along with other European healthcare systems, continues to struggle with hospital sustainability. This has been severely impacted by COVID-19, and it's not a problem that just faces hospitals here in the NHS and the wider UK, but also across Europe, in particular Germany and others, will feel the pain of returning back to business as usual, following what we hope is a rapid rollout of the vaccine and a return to life as normal, which I'm sure we're all really looking forward to. Some of the problems that we've had in healthcare are driven by a growing and aging population, expectation around the range of services that public systems will provide, an increase in chronic conditions, and also the cost of the quality and safety agenda. The NHS here in England, we know, is changing with the development of integrated care systems, which need to be up and running from the 1st of April next year. And also the Legacy Sustainability and Transformation Programme, STPs, which have, to be fair, encourage the back office consolidation and working collaboratively. But there's probably more work that could be done in that particular area. And that's of particular interest to our company, Genmed, where we believe that we've got a lot to offer in supporting that development. Austerity measures have resulted in ageing hospital estate and medical equipment. We know that the government have given a commitment to build new hospitals over the next few years. But I think it's fair to say that we know that won't be enough to cope with the points that I've raised already. And we also know that much of our medical equipment is old and some of it is in fact obsolete. I recently looked at a report that was written in 2013, which identified that in radiology alone, that the NHS in England needed £1 billion of investment for what is old and also obsolete equipment. And to give you an example of where the NHS falls behind other healthcare systems, we have currently 7 MRI scanners per million of population in the UK, compared with 30 per million in Germany. So from a diagnostic perspective, incredible additional capacity there in Germany. Clinical asset registers in this country also indicate that on the lower cost devices that surround a typical bed, so syringe drivers, monitors, pumps, all of those types of items, we have on average in the NHS 30 per bed, compared with the standard across Europe that's viewed as being the gold standard of 12 to 15 as best in class. So on those lower cost devices, we have too many. So the question is, how are we managing them? How are we tracking them? Have we got RFID? Are we losing some of those devices? So that is an issue. There is a significant and growing number of patients who we know are waiting routine elective surgery, and that's been massively impacted by COVID-19. The NHS, without doubt, we know for a fact, pre-COVID required additional resources, but there's definitely a need to return to high volume, low complexity elective surgery in key areas such as orthopedics, urology, ophthalmology, and other areas. And we have to get back to pre-pandemic activity. We know that the NHS requires additional resources, that's in people. It needs additional estate capacity through either new hospitals, reutilisation of existing facilities, or in fact modular buildings. Additional labour has been promised to the NHS, and the Prime Minister himself has pledged an additional 50,000 nurses and 10,000 additional doctors. But a significant proportion of those are going to be sourced from outside of the UK, and many of those niche organisations supporting international recruitment have been massively hit by COVID-19, with limited ability during the pandemic to bring people into the UK for obvious reasons. The other question will be, where will the private sector sit in terms of NHS recovery and driving down waiting lists in the coming months and years? And what will the cost be in comparison with current NHS reimbursement? I read recently in HSJ that the NHS is currently spending around about 400 million per month with the private sector to support us throughout the pandemic. Without doubt, I do believe that the NHS will need support, but at what point does the private sector return to business as usual? We know that there are many major reconfigurations which are moving forward despite operational pressures and the second wave of the pandemic. But I guess what is crucial is whether NHS-I/E can accelerate the approval of business cases to get these new elective surgery centres up and running very rapidly. Without doubt, this is going to be an interesting and challenging time for emerging ICSs as they look to be fully operational from April 2021. Next slide, please. So, who are Genmed and what makes us different? So, as a company, we have extensive experience in working at the NHS at all levels. We've also got experience from other healthcare systems across the UK, Europe and North America. We have a deep understanding of the medical device and also pharma industry. Many of our people have actually worked in those particular areas. We currently manage over 200 contracts across 40 NHS trusts and have a portfolio valued at about £315 million. We have a number of BPO contracts with private hospital providers in the UK and Ireland. But also, we don't do everything ourselves. We have a number of key partnerships with other organisations, including clinical partners for waiting list initiatives, overseas recruitment partners for doctors and nurses, experts in clinical and biomedical engineering maintenance, and finally, partners in the provision of data intelligence, which Simon Woonwell will elaborate on later. I think the big influence from our perspective has been we have been a disruptor in the marketplace. I don't like to use the phrase we're a disruptor, but I think because we are not an OEM, we are not driven down a particular route, we can offer more choice. And I think that with the advances in clinical practice, the preference items from clinicians, I think it's important that as a business, we do offer that choice. We are vendor neutral, and it allows our customers to develop a best-in-class solution for their clinical areas. And then probably most importantly, partnerships. We work with our customers in partnership to ascertain what clinical facilities or technology they need to support their strategy and workload. And I'll talk a little bit about that a little bit further on in the presentation. Next slide, please. In terms of what are the possible components of a managed service? So first of all, risk. Risk, if you have clinical downtime, passes to Genmed. So effectively, if the facility is not available, you cannot operate on patients, or we're operating an endoscopy suite or a radiology suite, risk passes to Genmed, and we would have to reimburse the hospital for that downtime. And that's really important. We have got substantial skin in the game. We offer favourable interest rates for asset-based finance. Now, we all know that asset-based finance interest rates are low at the moment, so we can take advantage of that when we look at the needs of the NHS with regards to additional capacity or refreshing their equipment portfolio. We're a back office service provider, and I think this is really crucial, particularly when you look at the back office developments of STPs and ICSs. We process over 3,000 invoices per month for our NHS customers, which gives significant back office savings, takes pressure off our creditor payments, and also procurement workload. So I think that that's fairly significant. We have strong account management, as you would expect, but really importantly, we have integration with our customers through our on-site team. So we have members of the Genmed team who are basically incorporated within the hospitals themselves. We take management of all equipment maintenance, which is really important, and an area which I personally believe needs to be explored further for additional benefits and savings. We work on long-term investment plans. Capital allocation within the NHS has always been a challenge, particularly around a capital allocation for a particular year, rather than a plan that embraces several financial years. I know is traditionally difficult because of the spending rounds within the NHS. So we have the ability to long-term plan with regards to both your business and also investment that's needed to support that business as well. We can also support the latest innovations in line with advances in medical science. A good example of that would be the contract that we have with the NHS Blood and Transport Service, where we've adapted the contract, we've bought new equipment, new harnesses to effectively collect plasma that's being used for patients who unfortunately have been in ITU because of COVID-19. Really important development, and because we are flexible and agile, we were able to procure those extremely quickly and support our customer. We've also got rapid access to design and build teams. We know that EU procurement rules make the procurement process slow and sometimes painful. So when new developments are required, which they will in the future, we can do that quickly and at pace. Next slide, please. So people often say to me, you're a managed equipment service provider, but we're not. And the definition that we use as a managed services company is that a managed service contract focuses on the clinical output rather than around a piece of equipment, which in turn leads to more substantial benefits around savings, administration, and linking of other services. And we'd like to think that, where we've got contracts, let's say in a surgical area, that we have the breadth and experience to extend that across other areas within a hospital. But for me, one of the fundamental differences between an MES and an MSc is the fact that we actually take risk. And if our customers, can't operate, or we impact their clinical practice, then we actually pay a penalty for that. Next slide, please. So I'm going to talk first and foremost about the partnership that we have with South West London Elective Orthopaedic Centre. Many of you will know it's referred to as Swellihock. What is Swellihock? Well, it's a tertiary orthopaedic centre. It's hosted by Epsom and St Helier, who are the lead trust, but also incorporates St George's, Kingston upon Thames, and Croydon. So what were the issues that faced Swellihock before their relationship with Genmed? So first and foremost, insufficient capital to develop the service in line with the needs of the executive team. And I think one of the big issues, and I think this was probably around the movement of NHS capital from one hospital to another, meant that that couldn't be pulled across the partnership, and that the requirement for capital needed to be met through Epsom alone, which obviously wasn't palatable for Epsom as a trust in operating this facility across 4 organisations. Overall affordability would obviously be an issue as well. Short-term planning in terms of what I mentioned before, the inability to plan for developments over the next 5 years. And I'll come on in a few moments around what we've actually done in that space. Speed of execution, really important. I talked a few moments ago around EU procurement rules. They're slow unless the particular procurement is on a framework. Generally, revenue procurement is on framework, but capital isn't. So the ability to procure capital developments is a slow process. Risks to patients because the estate wasn't fit for purpose. That was something that was identified to me by the service director, Mary Richardson, that there were risks to patients because of the existing estate, and that needed to be addressed. And then very importantly, in a world of technology, data and artificial intelligence, being a big part of the future of healthcare, and particularly post-COVID, we know that the healthcare world is going to change. Data was a problem for the organisation. And then finally, the demands of 42, which I think is now 46, practicing surgeons having their own thoughts around clinical practice and, of course, product preferences. Next slide, please. So what did we do? First of all, I talk about our relationship with Swellyock and being a partnership approach. I think the word partnership is very often abused, but I do truly believe that the relationship that we have with Swellyock is an excellent example of an effective public sector partnership, public-private sector partnership, sorry, where we have excellent relationships across the C-suite, clinical staff, and operational managers. And both organisations fully buy into the fact that, like all good partnerships, we are better, stronger, and more resilient working together. And I think that that's the key component of the relationship that we have with Swellyock. We are better by working together. And I think for someone who's worked extensively in the NHS for 20 years and also in the private sector, being part of the PFI initiative back in the early 2000s, I think there's been some examples of where public-private partnerships haven't worked. I'm not saying PFI hasn't worked, but there have been examples with PFI contracts where that partnership hasn't worked. There are other examples as well. Maybe MP Fit would be another example, but there are lots of contracts where, you know, deep trust, working together collaboratively is something that, you know, some of the essential ingredients has been missing. So what do we do for Swellyock? We have the uptime of all equipment, 5 operating theatres and associated wards. The key for us is that we are engaged in long-term business planning, which incorporates resources, people, capital for new equipment, additional theatres, and also radiology. And if you look at what we've done in terms of capital over the last 4 years, we're currently in the process of building a new pre-theatre and theatre 6. We built an X-ray suite. We've replaced all of the beds, the anaesthetic machines, theatre lights, operating tables, diathermy machines. We've put in robots, and we are currently planning for theatre 7 and 8. So we've got a long-term plan. We can develop the service in line with the requirements. And that would be the same for any new elective surgery centre moving forward. We manage all of the third-party suppliers, and that's a huge burden that's taken away from the trust. Not only the whole P2P process, but also the management of all invoicing, associated queries. And everything we do is wrapped up into one monthly consolidated invoice with lots of rich data that sits behind it, but the cost of the capital, the cost of the people, the cost of all the services, the cost of all the goods are all rolled up into one invoice. And in terms of benefits to the hospital, that's 774 invoices per month that we process on behalf of just Swellyock, which is, you know, a significant benefit to them. As I've said a few moments ago, speed of execution is really important and something that's essential to the leadership of the organisation, and we can move faster than traditional procurement methods. We are contracted to bear the risk, as I said, of equipment being available to carry out planned procedures. We carry out all of the purchase to pay activity, and we provide complete and utter flexibility to meet the changing needs of the service. I mean, again, going back to the director of the service, Mary Richardson, she describes us as having her own procurement and supply chain department, or that's part of what we do, embedded within the function. The other thing that we've done is implemented an inventory control system, incorporate product scanning at point of use, a scan for safety solution that manages all of the inventory across the whole of the centre. And ultimately, by working with Blue Sphere, the theatre system for the organisation, we actually provide surgeon level costings, which looks at the cost of all the components, the cost of the procedure itself, and the length of stay. So a complete financial picture of the costs. We've got a theatre improvement group that we've put in place, and this has been really critical to the way that we've built the relationship with the organisation over time. So we've pulled together bi-weekly meetings to focus on efficiency, collaborative working, and that comprises of all of the key people: orthopaedic surgeons, nurses, stores, materials management, healthcare assistants, finance, etc., etc. And we've been able to look at rationalisation and standardisation in a number of key areas, which has delivered substantial savings over the first 4 years of the contracts. I've mentioned already savings, but if you look at the total savings that we've made, cost improvements around about 1.3 million, and overall savings, which include VAT benefits, of up to 5.2 million have been made thus far. I think the other crucial thing to mention about Swellyock is how we've worked together and how, very importantly, they've moved closer to business as usual before the second wave in the pandemic. And between June and July 2020, Swellyock moved from delivering 17.3% of total operations delivered at the same time last year to 73% in July at the same time last year. So significant moves towards back to be business as usual. Next slide, please. So where do we see the future? And what you see in front of you here is Genmed's 3 pillar side. If you look at the slide to the left, the box with the very nice supermarket cart, I think we sometimes take for granted procurement and supply chain, but I think it's fair to say that we've all felt the pain of when a supply chain breaks down, and COVID-19 and PPE is certainly no exception. And that's been a lesson for healthcare systems, not just in the UK, but around the world. We have significant purchasing capability. We use national contracts where they represent value for money, but we also have access to pricing on a European basis through an international collaboration of hospitals who've got a consolidated spend of 15 billion. But we're not only looking at price, and there are significant price variations across Europe that I'll talk about very briefly in a moment, but we're also looking at clinical variances across Europe, which are significant. I think in the procurement community, and I think this is driven by the pressure of cost improvement targets, there is a big focus on the reduction of price and cost. But I think that we need to work more closely going forward with our clinical colleagues and with the device community to look at what is, applicable for particular procedures, and actually look at substitution in a way that maybe we haven't in the past. But I'll come on to that in a few moments' time. Also, with the move to ICSs, the need to utilise the estate and minimise on-site storage. We're looking at the provision of consolidation, off-site consolidation to support ICS footprint, moving away from bulk logistics drops or even traditional logistics routes that are currently provided. So off-site consolidation options for ICSs, particularly if you look at the logistics complexities of areas around London, that would be something that would be of real benefit. I also want to re-emphasise our strong service offering and movement into new areas. I won't talk about our service offering again, but it is comprehensive. We have a number of new initiatives, and that includes aseptic units, but we also are working with partners who can help support waiting list initiatives. So in relation to moving back to business as usual, not only providing developments to existing structure, providing modular buildings, but also working with other partners who can actually carry out clinical activities to support waiting lists, with partners that can provide additional resources through international recruitment, and those that can also provide support in areas such as clinical engineering and best value for money. Finally, we know that COVID-19 will change the way healthcare is delivered, particularly in areas such as radiology. There's talk of further industrialisation of pathology and through new surgery centres. And data is going to be a key component of that going forward. I recently attended an event where I was told that only 20% of patient data is actually collected through hospitals. So the bulk of data around patients is mainly within the community, certainly within GP practices and within clinical pharmacies as well. Next slide, please. Moving on to a slightly different area, when you look at clinical practice and the classification of items, I think it's really important that we do get beyond the price and that we work with clinicians to identify what clinical products are fit for purpose. And what I am presenting to you today is an example of where a group of clinicians, electrocardiologists or electrophysiologists actually came together to look at the key component parts that make up a single chamber pacemaker. And what you see is the evaluation criteria that was determined by these electrophysiologists for this particular type of pacemaker. And then on the right, where you can see the green and red lights, you will see the performance of those against those areas by the leading manufacturers of pacemakers. Now, this data has been anonymized, but the very interesting thing that came out of this particular exercise was that some of the leading providers of devices did not score the highest in terms of clinical preference, in terms of output-based specification that you can see on the left. And that the two providers that came out with the highest score, both ranked at 32, also offered fabulous value for money in terms of the price element as well. And the decision that was subsequently made huge savings across the organisation, but was not at all driven by price. It was driven by clinical preference. So it was a really interesting evaluation that was carried out. It was a group of university hospitals in Germany, but the results in terms of who came out top from a clinical perspective were not as you would have anticipated. Next slide, please. This also shows where prices vary considerably across Europe. And I say this in the light of the national initiative that we have with regards to the towers. But when you look at the price of medical devices that are paid within this country and across Europe, very often price isn't always determined by volume. Yes, volume is an important part. Compliance is also an important part as well. But also, the price can very often be driven by the payer side, so the reimbursement back to the provider, which means that some hospital systems around Europe pay a huge premium for products, but the lowest cost countries in general are Germany. Now, where you can see here, we've got prices from Belgium, Sweden, France, Switzerland, Germany and other countries. We're not showing the price from England, from the UK, but our prices normally sit above German prices. So significant savings in areas such as cataract lenses, as an example. Next slide, please. And then one that really interested me was the variation on total hip replacement. So the 4 items that make up a hip replacement: the stem, the cup shell, the inlay, and the head. If you look at the variances across Europe, if you look at France at 2,095 compared to Sweden at 764 for exactly the same products, exactly the same manufacturers, again, huge differential in prices. And many of our prices here in the UK sit at the average German price or higher. So lots of work for us to do in Genmed and for our national procurement colleagues in the towers around analysing clinical preference items and also looking at prices. And we believe through Genmed that we've got a real handle in this particular area. And my last slide, please. Thank you. Finally, please don't take my word for it. We've worked collectively with Swellioc for the last 4 years. And the last slide that will be made available to all of you summarises the relationship that we have with the organisation. Thank you very much for your time.